and superimposed infection. We're getting a lot of questions, so we're hoping we could help guide some, give some information and help guide you guys. So if you have any question, feel free to unmute and ask us, or type the question in the chat box.
Hi, Dr. Horn with MD Stewardship.
Dr. V.
So yes, our goal today is to discuss superinfections with COVID-19. So we're going to talk about bacterial and fungal infections in patients with COVID-19. So we hope this answers a lot of your questions. And really, we want to talk about antibiotic use. So we're going to talk about diagnosis of bacterial and fungal infections in COVID-19, and also antibiotic use with patients that have COVID-19, and then especially in patients that have COVID-19 and that are on a ventilator. So these are the specific questions we'd like to address, but if there are any questions that you have, please type it in the chat or unmute yourself, and we're happy to answer any questions. Okay, so first we wanted to start with definitions. So we wanted to define secondary and co-infections. So secondary infections, and you can have secondary infections with bacterial, viral, or other pathogens. And secondary infections have been described with other viruses. You know, we talk a lot about influenza and secondary infections with like MRSA and things like that.
You know, during influenza season, one of the things you always worry about is staph infection, Staph aureus, and strep pneumo, superimposed pneumonia. So, you know, we didn't know a lot about COVID-19 when all this stuff started a year ago, but I feel like we have more data now, so we could talk about, what percent of co-infection are we seeing?
Right, and secondary infections, it's essentially an infection following another infection, and co-infection are two infections at the same time. And you know, secondary, we'll use these terms interchangeably, I think, with COVID. Really, secondary or co-infection, kind of think of it the same way. And risk factors for secondary and co-infections. So, and these are risk factors. Here we have this table here. It's kind of risk factors for infection with gram-negative pathogens. So this is just gram-negative pathogens. They don't have others on here, but we wanted to show it as kind of an example. And these patients with COVID are at risk for gram-negative pathogens as well as others. But and it's just what you'd think it would be. It would be if they're getting broad-spectrum antibiotics, if they have other people they've been around with multi-drug resistant organisms. And one of the biggest ones is hospitalization. So if they're hospitalized, they're at bigger risk for gram-negative pathogens than someone that's not hospitalized. So these patients with COVID, they're in the hospital for long periods of time, puts them at risk for, well, other things as well with gram-negative pathogens also.
Yeah, and I think when we talk about gram-negative, is we're talking about, you know, there's like Pseudomonas and Achromobacter, really bad gram-negatives that we see with hospital-acquired pneumonia. But one thing to remember is, like, not everybody that has COVID-19 infection, and you know, if you're worried about a secondary pneumonia when they get admitted, you need to worry about these broad, like, bad gram-negatives. It's you know, usually you could focus on community-acquired bacteria. We're going to talk about that in a little bit. But I think you start looking into this, like, you know, Pseudomonas and such, like in this table it says, you know, hospitalized, and then they develop a pneumonia, then you're worried, then having a high degree of suspicion, just like we would for hospital-acquired pneumonia for Pseudomonas and MRSA.
Some of the diagnostic challenges to secondary and co-infections. Now, one of the diagnostic challenges is that if they get an infection while they have an infection, you know, it's important to follow the patient very closely and to see if they're worsening in any way. I think the classic example with influenza is that they have influenza, they seem like they're getting better, then all of a sudden there's an acute worsening. And so that would be an example of a secondary infection where they seem like they're getting better, and then they get a bacterial infection on top of the viral infection. So there's all of a sudden this worsening. And it's hard to follow patients and you know, closely enough where you're seeing that, you know, if there's a change where you say, you know, you have to have a high level of suspicion for a bacterial infection to start antibiotics. So the goal would be to try to keep them off of antibiotics if you don't think they have an infection. And then if they have an acute worsening, have a high clinical suspicion for bacterial infection on top of their current infection. But we know this is a problem here because in previous pandemics, bacterial infection on top of a viral infection is a big reason for morbidity and mortality. So the mortality goes up, and they look at these pandemics and they'll do autopsies, and then they'll do the autopsy and to see what they died from, and then a high percentage of them will have a bacterial infection when they do the autopsy.
And one thing to remember with COVID-19 the last year is that because we didn't know, we've been using a lot of antibiotics across US for anybody that gets admitted with COVID-19 infection, because we didn't know how to tell them apart. Do they have a co-infection? Do they have superimposed infection? So patients are getting really, really broad spectrum antibiotics for prolonged period of time, and also broad spectrum antibiotics for community acquired pneumonia. But what we have learned is that we need to go back to how do we treat community-acquired pneumonia even if they have COVID-19, and how do we treat hospital-acquired pneumonia even if they have COVID-19, kind of like, kind of go back to the way of how do we treat those infections we already know how to treat, because, we're seeing that there's more resistance, more C. diff, and antibiotics are being used really broadly across US.
Yes, and that's exactly how I see it. Patients or the clinicians that we work with will say, well, I'm not sure if they have a bacterial infection, so I'll start them on something. What's the harm? And that's the general harm that we see with antibiotics that are given but not needed. And so you have the resistance rates going up. You have your community and your hospital, they're at high rates of resistance and resistant infections, which is kind of a cascading effect of needing third line antibiotics more and more because of the use.
And I also think, sometimes, I don't know your opinion, Dr. Horn, but like when you give so much antibiotic, I think it puts pressure in the patient to have like fungal infection too, because you're killing all the good bacteria.
Right.
So now we're seeing with COVID more fungal infection, which we will get to. So I think that might be a secondary outcome of using so much antibiotics as well.
This is what we'll see today in today's talk. So current data indicate that bacterial co-infections with COVID are relatively infrequent. So we'll talk about the percentages that some of the studies have seen, but it's less than 10%. And so the literature does not support routine use of empiric antibiotics. So if a patient comes into your clinic and you're suspecting COVID, so this empiric antibiotic would be like giving all patients antibiotics if they have COVID. And clinicians will say just to be safe, or it makes me more comfortable when they're on antibiotics. But really the important thing out of these studies are showing that the low rate of co-infections really suggests that the patients don't need antibiotics. So if you're able to not give antibiotics to patients that don't need it, that's really the goal with stewardship. And we're also going to see objective findings that increase the concern of bacterial superinfections, like the leukocytosis, lobar consolidation, evidence of necrotizing infection on chest imaging, and recrudescence of fever after initial defervescence. So they're worsening after they're initially getting better. And fungal superinfections with aspergillus. So aspergillus, this is a really important topic, and we'll go through some of the new information that's come out about it. And it's a concern. So aspergillosis in COVID-19 patients, and that's something that, you'd have to see these studies to really appreciate and be sure that you can recognize it.
Yeah, and CDC has a really nice link to fungal infection and COVID-19 as well. So if you need that link, you could just Google CDC and aspergillosis or fungal infection. But we're seeing this emerge more, so we wanted to kind of talk to you guys about that.
So first, we're going to start with bacterial co-infections. Now, each of these, we're going to go through a few studies, and these studies are actually on the Infectious Disease Society of America website, and they go through them. And so we thought those would be great to go through and discuss. And so this was one, it's bacterial and fungal co-infection in individuals with COVID. And this is a rapid review to support antimicrobial prescribing. So stewardship with COVID-19. And they looked at 18 studies, over 7,000 patients, and they were looking at the incidence of bacterial and fungal co-infections. And the key findings that, and so this is the important part. Overall, in this literature review of 18 studies, there was a low bacterial co-infection with COVID, and the use of broad spectrum antibiotics was very high. So the low rate, so about 8% of patients had co-infection, but a much higher number, a lot of people were getting antibiotics.
Yeah, and if you look at the study, 8% is a small percent out of 7,000 patients, but over 72% of the patients were getting antibiotics. And I think now that we have learned so much, we could do better, all of us together, now that we are getting more data and studies that show that not everybody needs antibiotics.
Right, and so when you see a patient, it's important to think about, what percentage of these patients usually have infections, and even in these patients, it's going to be the sickest patients that are on a ventilator that are most likely to have a secondary infection. And so this is another study. This is another review and meta-analysis. This was looking at 30 studies, and this was a percentage of these was out of China, and so they were looking to essentially the same thing that the last one was looking at. What percentage of patients have bacterial co-infections? And it was saying 7%. And so the last one was 8%, and this is 7%. So it's reassuring when you get studies that show about the same percentage.
The last study had over 7,000 patients, so that's a really big study, and here they had over 3,000 patients. I really like when you have multiple studies that over and over again reproducing the same data to show the bacterial infection is low. So I feel like that's very reassuring.
Yes, and that's what I think is that, when you see these studies and you kind of look at it, you look at the study and say, well, it looks okay, but then when you get multiple studies showing about the same percentage, it's very reassuring. And this is another one. This is looking at co-infections in hospitalized patients. This is a retrospective, and this is looking at about 1,000 consecutive hospitalized patients. And this one was in Barcelona. And they found that co-infections were uncommon. And a few patients developed superinfections during hospitalization, and those that did had a longer hospital length of stay and a higher mortality. And that's something you would expect, is that, if there's a secondary infection or co-infection, those patients usually stay in the hospital longer, and that's, I think, with anything in the hospital, right?
And again, I feel like they reproduced that 7.2% that had a bacterial infection. So over and over again, we're seeing that 7 to 8% of bacterial infection.
And when you're looking at the organisms that they were identifying, now this one was in Barcelona, but a lot of things that they're identifying, and it'd be exactly what you'd expect, right? So it'd be, you're getting a lot of strep pneumo, and you're getting some Staph aureus, some Haemophilus. So these are the things that you'd expect to find, right? Yeah,
and I would, if you're worried about like community-acquired pneumonia, I would use our recent community-acquired pneumonia guidelines where it says, you could do ceftriaxone and azithromycin to cover the major organism. And if you're a patient of high risk, like you have past history of MRSA, past history of Pseudomonas, then you could consider expanding it. But otherwise, stick with like what we would do for community-acquired pneumonia. Because what we see a lot is when patients with COVID-19 get admitted, unfortunately, even if it's community-acquired, they get put on like Vanco, Meropenem, Levo, really broad treatment. But if you're just worried about community-acquired, I think we need to go back to the practice of what do we do for community-acquired pneumonia and antibiotics.
Yes, I completely agree. Now, the patients that have resistant organisms are going to be the patients that ventilator-associated pneumonia that have been in the hospital for a long time. But if they come in with a pneumonia, you'd want to do just the community-acquired pneumonia regimens that we're familiar with.
Yeah,
right?
Unless you're a high-risk patient and has had past history of stuff. But if you're coming with COVID-19 infection, you're a 65-year-old patient from home, and you're getting admitted to the hospital and you're worried about pneumonia, If they have no other risk factor, we could stick with ceftriaxone and azithromycin if you need antibiotic, if they fall into that 7 to 8% category.
Then here's some more of the organisms that we're seeing.
And this is for like hospital acquired. So for ventilator acquired, they're seeing Staph aureus more, Pseudomonas, Stenotrophomonas, Serratia, Club pneumo. So we're seeing more and more gram negatives. And so I think what's important is, and this you kind of start seeing after the patient being in the hospital for like 5 to 7 days. You know, they got intubated, they were doing okay. All of a sudden they're getting worse again. Now you're worried about a pneumonia that they acquired in the hospital. Then it's reasonable to cover broadly. But we also want to talk about tools that can help you de-escalate as well.
This is another study. This is empiric antibacterial therapy and community onset bacterial co-infection in patients that are hospitalized with COVID. And, you know, a lot of these studies showed pretty much the same thing, that a lot of people are getting a lot of antibiotics that weren't needed.
Yeah, in this study, they showed that early antibiotic use can range from 27% to 84% of the time. Earlier study, we used antibiotic over 72% of the time in patients. So a lot of unnecessary use is happening.
The prevalence of confirmed community onset bacterial co-infections was low. And despite this, half the patients received early empiric antibacterial therapy. So antibacterial use varied widely by hospital. So, you know, and I think this kind of matches people's emotions and how nervous they were with patients with COVID, which is understandable.
Yeah, I think now that we know more, and it's also wonderful that, you know, the COVID-19 cases are going down across US. I also think a lot the hospitalization is going down. So, you know, we could focus more on the patients now because we were so, you know, stressed taking care of so many patients. Now we could, you know, step back a little bit and start thinking about some of the practices that we have been doing and what we have learned.
So then, now we'd like to talk about ventilator-associated pneumonia with COVID. And this was a retrospective observational study, and it was looking at VAP and secondary infections using a combination of culture and a multi-pathogen array. So that's like PCR. And they looked at the lung microbiome composing of this RNA analysis, and what did they see? They saw COVID-19 patients were significantly more likely to develop VAP than patients without COVID.
What was really cool about this study is like they did a really, really sensitive test like PCR, and they looked at like anybody in their respiratory samples to see if they had what kind of bacteria, and it was able to detect it. So I thought it was a really cool way of like looking at superimposed infections when you're on the ventilator.
Yes, I think it was a good way to do it. And they looked at the distribution of organisms causing the ventilator-associated pneumonia, and it was similar in the two groups. So this really tells us that we can use, you know, what antibiotics we're already using in our hospitals for VAP on the COVID patients as well. So you wouldn't need to use different antibiotics and say, you know, you could just go with what you're already using in your community, in your hospital.
Or you know, depending on the antibiogram.
Right.
And what you would use for your VAP treatment would be the same as what a patient with COVID that develops VAP. So you don't have to, you know, jump to another higher, you know, we don't have to go to tigacycline or Zabraxa or Avicaz. If you're, you know, if you know your antibiogram, you could stick with what you would do for other VAPs.
And they identified 3 cases of invasive aspergillosis among the COVID patients, but not among the other patients. So that's something that we'll talk about also. And here, this is the curve. And so this is looking at patients with COVID and without COVID. So the COVID one is in red, and this is time to VAP, time to ventilator-associated pneumonia. So the patients with COVID developed ventilator-associated pneumonia faster than the non-COVID patients.
And I think that when you have some of the things that I've been noticing is like when you have COVID-19, there's a lot of, when you have severe infection, there's a lot of structural change like fibrosis in your lung. So I think that's another big reason why our patients on ventilator, severe disease, are developing pneumonia as well. They're retaining secretions, getting more gram-negative pathogens. You know, in my mind, I think of them like kind of acting like cystic fibrosis patients, you know?
Right, and I'm seeing a patient today that we did a CT scan and they said COVID-related scarring is so really what this is saying is that patients with COVID that you're seeing like in the clinic, or you're seeing they're coming in from the outside, the rates of infection are low, but when they become intubated, when they go on a ventilator, the rates are higher, right? And so we'll discuss a little bit about, the antibiotics in those patients as well. Now, conclusion, COVID-19 is associated with an increased risk of ventilator-associated pneumonia, which is not fully explained by the prolonged duration of ventilation.
Still more information to follow. I think we still don't know a lot.
Yeah.
But I think the fibrosis component may play a little part as well.
And the diagnostic workup.
Yeah. So I think it's really important what kind of workup do we do, right? So you have a COVID-19 patient who's getting admitted. They're 65 years old, coming from home. And then, your suspicion is maybe they might have a community-acquired pneumonia on top. Can you help determine that? I think it's really important to get a sputum culture. It's, if you're able to get urine pneumococcal antigen, urine Legionella antigen, I think that's really helpful. And then blood cultures, if you have high degree of suspicion, because of strep pneumo, for example, 40% of the time that'll show up in the blood. So it's kind of like including for your ventilator-associated pneumonia too. I think we need to be like getting sputum, urine antigen, blood cultures, and also procalcitonin. We are a big proponent of procalcitonin if we use it correctly. Is going to be important at trending the procal. So if somebody gets admitted with community-acquired pneumonia, is it more than 0.35? And, is the trend going up or down? That might kind of help you with kind of deciding bacterial infection versus not. What do you think, Dr. Horn?
Yeah, I like using procalcitonin. And there are some patients where, it can be, there are some patients where it's not as helpful. But in the patients where it is helpful, it's very helpful because you can just stop all antibiotics.
So I usually say it's not diagnostic tool, right, but it's a prognostic tool to kind of help you follow and see if you're doing the right thing.
Right. And some people will say, well, if you're not going to base everything off of it, why would you get it? And you're not going to base everything off of the WBC either, or just one. You don't just take one thing. You kind of take it as a whole and look at everything together. But I like using it. I think it's very helpful.
And one other thing to remember is that sometimes procalcitonin, people say that, they have acute kidney injury or hemodialysis patient. So their procal of 10 is because of that, and that's actually not true. If you have acute kidney injury or hemodialysis, your baseline procal goes from 0.35 to 2, averaging out. If it's 10, it still gives you internally, it could still be a bacterial infection. And other tools that we like to use is like CBC with manual differential. So then you could look at the immature neutrophils, which are called bandemia. If it's more than 5% of total, if your immature neutrophils, that might be bacterial infection. If it's more than 10%, like high degree of suspicion. So when you have the COVID patients coming in, and if they're, you're not sure if they have community-acquired pneumonia or not, you're getting all this lab work, and then you see their bandemia at 15% on admission, then you're like, okay, I should probably give them ceftriaxone and azithro, and then I could treat and de-escalate.
Yeah, I agree with everything you just said. And the duration of treatment, so if you have a high suspicion that they have a bacterial infection, it's okay to start antibiotics. And so I don't want people to think that we're saying don't start antibiotics.
Yeah.
I want it's completely fine to start. I mean, as long as you give for 5 to 7 days and then discuss stopping antibiotics. And you can have they call them antibiotic timeouts, where you when you see the patient, you just say, is the patient on antibiotics? Do they need to be on antibiotics? And just think about de-escalating or stopping. And so about 5 to 7 days, if it hasn't made a difference at all, then I would recommend stopping antibiotics and just monitoring off of antibiotics.
Yeah, a lot of times, like what I'm finding, especially in my critically ill patients who are intubated on a ventilator, sputum cultures are so helpful, because you're treating them with something and then you have Pseudomonas growing. So I think getting culture data is really key. And one of the things that we don't do as much is getting sputum culture. And I think in our patients who are critically ill in the hospital, they were doing okay, getting worse, getting a sputum culture. If the patient cannot produce a sputum, working with a respiratory therapist to see if they could induce a sputum. But I think that'll give you more, another point of data to kind of help you treat the patient.
And this was an editorial. This was the challenge of ventilator-associated pneumonia diagnosis in COVID-19 patients. And so I think there are a lot of people recognizing that a number of patients in the ICU, they get intubated, they're put on a ventilator, and then they kind of just linger there for a long time. And so they can just stay ventilated, and there's a concern for infection up front, and people get started on antibiotics and then never stop.
Yeah.
And so, and that happens everywhere.
Yeah.
Yeah.
And I also think we didn't know before,
Right.
but now that we know, when I think, even if you look at the bottom parts, it's okay when you worry about pneumonia, ventilator off community, start them on antibiotic. But I think the duration is going to be really important, just to stick with the 7 days like we would treat for any other pneumonia, instead of doing a longer period of antimicrobial use.
So with this one, it starts out up here at the top, clinical features suggesting HAP or VAP. Yes, immediate respiratory secretion sampling. And this, like you're saying, the goal is going to be to try and get a good cultures and try to get an organism. And direct microscopic specimen examination plus or minus molecular testing. That would be like
respiratory pathogen screen.
Yeah.
Some people now have like pneumonia PCR for bacteria. So if you have that, you could use that.
So hemodynamic instability or severe hypoxemia. Yes, start antibiotics immediately. And then one of the things I just want to highlight here is that at the bottom here, it says shorten antibiotic exposure to 7 days or use procalcitonin guided strategy. So that's one of the reasons I like this, is that if you're going to start, that's fine.
Yeah.
And then, reevaluate at 7 days. And if they're doing okay or that hasn't made a difference, then consider stopping.
I think that's going to be the takeaway from here today.
Yes.
Is the duration of treatment. We need to not prolong the duration of treatment and do what we would do for anybody else with VAP or HAP,
Right, exactly. And so, sometimes we'll get calls from clinicians and they'll say they've been on, antibiotics. They're intubated in the ICU. They've been on antibiotics and it's been unchanged for about 15 days or so.
Yeah.
And then, our recommendation is going to be to consider stopping antibiotics and monitoring off. Yeah. So fungal infections in COVID-19. So this is a good topic, fungal infections. And one of the reasons is because, we're going to talk about aspergillus. And this isn't something that, you'd think about without seeing the studies, really,
Yeah.
right? Because these aren't the patients. Traditionally, people have talked about very immunosuppressed patients, transplant patients, patients that are very immunosuppressed. And so we're seeing aspergillus in COVID-19 patients.
Yeah, and aspergillus also Candida infection as well. But but you're right, John. We never thought about like fungal infection with viral and superimposed. Usually in our mindset is like, if you're like transplant patient, your chemotherapy patient or HIV patient. So we always thought really immunocompromised patients had really a lot of fungal infection. But in COVID-19, they're noticing more Candida and aspergillosis. And that's kind of what we talk about here. Aspergillosis is usually seen in immunosuppressed host, but more and more that we're seeing in COVID-19 patients. So how do we diagnose? It's kind of a diagnostic dilemma. How do we figure out people have aspergillosis? If you go to the next slide, there was a study, about 5% of the patient with COVID-19, they saw they had maybe a fungal superimposed infection. Invasive pulmonary aspergillosis emerging as a serious secondary infection. And 2 studies have indicated excess mortality. So what they notice is it's still a small percent, but if you have fungal infection, then your mortality is much higher compared to not having fungal infection. So European Society kind of gave us a little bit of like a helpful guidance. How do you figure out they have, fungal infection? So they kind of taught us like, is it proven? So do you have culture growing, or can it be possible or probable by using some serological markers?
And it's difficult to diagnose aspergillosis anyway.
Yes.
And so that's why it's hard to have a high clinical suspicion in patients that you wouldn't normally expect it to be there. So if it's a transplant patient and you're able to do imaging and you're able to see things, but COVID-19 patients, they don't have clear imaging in the first place. So it's hard to get the classic imaging that you'd see on CT scan, and it's hard to diagnose it. So it's already hard to diagnose it, and in COVID-19 patients, it's even harder.
Yeah, and just to remember, they're seeing fungal infection in critically ill COVID-19 patients. So not in the, they're coming in and getting better and they're on the floor. Yeah. These are patients who are getting, they're intubated for a prolonged period of time and they're not doing well. Then we kind of have to start thinking about, is there a fungal component?
That's a really good point. These aren't going to be patients coming in, into your clinic and then suspecting it. These are patients that are going to be intubated and have been on a ventilator for a long time. And this is another reason why we have to try and follow the recommendations as far as how long to give dexamethasone and not keep it going. There's sometimes we'll see patients that have been on dexamethasone a really long time. And so we'd recommend, just try to following the guidelines that are out there. And so here, this is epidemiology of invasive pulmonary aspergillosis among intubated patients with COVID-19. And so this is, so essentially they're looking for aspergillosis in these COVID patients.
And the way they try to diagnose is they got either bronchoalveolar lavage specimen, or you could also get something called galactomannan and beta-D-glucan or fungital, which is from your blood. So they use indirect markers to see if they had aspergillosis.
And when they did, this is what they saw. And really, so this is coronavirus associated pulmonary aspergillosis. That's kappa. So coronavirus associated pulmonary aspergillosis. This is the new term for it that has been coined since this has been seen. And this PIPA, this is kind of the old way of this is the possible probable. Mm-hmm. And so when they're looking in these patients, and really one question would be, if it grows, is this going to be colonization or is this going to be infection?
Yeah, so they address that in the guidelines too. They talk about it. They talk about, like, it's hard to say if the patient is critically important. They're recommending you just treat them for 6 to 12 weeks.
Right, and if you do, there could be colonization in a patient that's feeling fine.
Yes.
But if they're critically ill, you would err on the side of treating it. And yeah, for sure.
And in this graph, what it basically shows is if you had COVID-19, if you had a fungal infection with aspergillosis or without, and if you had COVID-19 plus aspergillosis, then your mortality was much higher compared to if you had COVID-19 and didn't have aspergillosis.
Right. So it's highlighting the importance of having a good clinical suspicion and treating if there's any concern for it at all. And that's kind of how I would summarize it.
Yes.
Because, if you have a patient that, especially if you're growing aspergillosis or aspergillus from, a sputum or if there's any concern for it, you would want to be treating them very aggressively. And this is another one that was a national strategy to diagnose COVID-19 associated invasive fungal disease. So they're trying to highlight the importance of identifying it and trying to get people to recognize it and treat it.
And again, in this study, they found, when they looked at fungal infections in general, you had about 14%. Overall mortality, though, when they had fungal infection, like the other studies showed, was higher at 38%. So in these critically ill patients, I think the key takeaway is look for fungus, get BAL or sputum culture, and then also treat if you guys find it.
Here, defining and managing COVID-19 associated pulmonary aspergillosis.
So Lancet published recently a guidelines, and what they're saying is, you can skip to the next slide. There's a lot of numbers on here, but basically what they're saying is fungal disease occurs frequently in critically ill, mechanically ventilated patients in COVID-19. Survival benefit observed in this patient receiving antifungal therapy implies that you need to propose diagnostic and defining criteria appropriate. So basically, they're encouraging us to get treatment. They don't know about prophylaxis yet, but they're talking about giving treatment, but getting the right type of cultures. So going back to getting bronchoalveolar lavage, sputum, trach aspirate, whatever you can do to get some cultures if a patient is really, really critically ill, and if you have a high degree of suspicion for like aspergillosis.
Yeah, and I thought this was good because it shows the pros and cons of diagnostic procedures. So there are good things and bad things with each one. We're not going to go through each of them, but we just wanted to show that there are different ways to collect it, and there are different ways to test, especially like galactomannan and PCR. And then as far as treatment goes, so here at the top, if you have this COVID-associated pulmonary aspergillosis, now if it's azole sensitive, you can give voriconazole or isovuconazole, and azole resistant is over here.
Yeah, so let's say you have aspergillosis in a patient and they're crashing, they're not doing well, you don't know the susceptibility yet, and you could do like ample, higher degree of antifungal. But if they're doing okay, but then you recovered aspergillosis, then I would say voriconazole is still like your go-to for aspergillosis.
That's the number one. Yeah, that's what I would do. I do voriconazole, and then
Or if you have kidney issues and you can't use IV worry, then you could use isovuconazole, and which would protect the kidneys and still kill the aspergillosis. So the green box is what I would say is important if you suspect, treat with these two drugs.
The duration of therapy is unknown, but expert panel suggests 6 to 12 weeks. So you'd be using 6 to 12 weeks for treatment.
And the serum galactomannan is helpful, just like procalcitonin. If it's elevated, you could trend it. So as you treat the patient, if it's coming down, it's kind of like a prognostic marker.
And these patients are probably going to be on the ventilator for a long time. And then if you're suspecting it, you can get a galactomannan and get some of these studies and look for it.
So takeaway for aspergillosis is if you have culture growing, treat that 6 to 12 weeks. You could use the serum markers to kind of help you with that. And the other takeaway for bacterial infection is that we need to treat patients as if they're community acquired, or hospital acquired, or ventilator acquired, but keeping the duration to 5 to 7 days each.
I think that's exactly. I think that's the main takeaway.
And that's all we had for today, and we will love any questions you guys have. Happy to answer. You could unmute yourself and ask us questions. I'll put questions in the chat box. We also recorded this session as well, so we'll send it to all of you with the slides and the video.
Yeah, I mean, it's very difficult to tell sometimes if they have a bacterial infection. But I do think, starting antibiotics is fine, just as long as it's not kept going for weeks and weeks. And
Yeah.
it's sometimes kind of hard to stop the antibiotics once they're started, especially if the patient's not doing well. But if you look and you say it hasn't made a difference, and when you started the antibiotics and you've kept them on it, and the things haven't really improved, it'd be worth stopping it, and then you can always restart if needed.
There's a question about, when do you say azole resistant or sensitive? Are you talking about voriconazole? Yeah. So, sometimes in certain areas you could get vori resistant aspergillosis.
Yeah, I don't think it's very common.
It's not very common. So I think for our go-to for the most part is voriconazole if you're just having aspergillosis. And when we go to isobuconazole is when you can't give IV vori because of it has
interactions.
It affects your kidneys, the carrier fluid. So then we do isobuconazole. So I think the go-to should be voriconazole.
And then patients with aspergillosis get sick, they do better with voriconazole than compared with amphotericin. So because they will do better, that you do voriconazole.
Oh, cyclodextrin is what's in IV voriconazole. So sometimes it affects your kidneys. So if you have AKI, then you could switch to isobuconazole. Well, thank you so much for joining us today. It was really nice to talk to you all, and let us know if you have any more questions or what we should cover. Thank you.
Yep.